I now invite Professor Dirk Dressler. Professor Dirk Dressler is from Hannover Medical School, Germany. I will take a couple of minutes to introduce him because there is. So, sir obtained his medical education from George August University, Frederick Alexander University, Erlangen, and Harvard Medical School, from Boston, Massachusetts, USA. And thereafter, from September 2008, he was appointed as a full professor of neurology and head of movement disorder section at the Department of Neurology, Hannover Medical School in Germany. Sir has a very elaborate literature behind him, in the sense that he has over 400 plus articles, book chapters, and abstracts. He is also serving as a project reviewer for the Wellcome Trust, London, UK, and the National Medical Research Council, Singapore. He has received an honorary professorship at the University of Santiago, and he holds visiting professorship to several universities, including that of Sao Paulo, Brazil, and Monterrey, Mexico. With this, sir, I invite you for your talk, which will be about cervical dystonia. Thank you.
Thank you very much for this kind introduction. Yeah, it's great to be here. We just found out earlier this day that the last time I was here was in 2017, I believe. So long time ago, and the city has changed tremendously. But when I'm here, I met so many people I knew from that previous visit and from international meetings. So it's really like, to some extent, coming home to motherland India and to Bangalore in particular. So thank you very much for the invitation, and especially for the organizational help from GUFIC and the great GUFIC team. So it was really, and it's still a marvelous experience for me and my wife to be here and to learn from you, to see how India has developed in the last couple of years. Yeah, as it was said in the program, I will cover cervical dystonia. Of course, I cannot cover everything about cervical dystonia. So, you know, there is a lot what we had been discussing and describing about cervical dystonia, about the natural causes or potential etiological aspects why people do get cervical dystonia. So all these things, unfortunately, I cannot be able to cover in this very short period of time I have. So I will focus a little bit on the practical aspect of treatment of cervical dystonia. So I will share with you some general thoughts, some algorithms we have developed, how to plan botulinum toxin for cervical dystonia. So why have we in particular been so interested in cervical dystonia, and why I think it is very important for this meeting and for you as users of botulinum toxin therapy in dystonia that we are that we are discussing cervical dystonia. Cervical dystonia is the most common form of dystonia, most common form of focal dystonia. It's not blepharospasm, as many people thought for many years. It really is cervical dystonia. The second aspect why I think it's important every once in a while to put that on the spot, the treatment of cervical dystonia is very challenging. You know, we have other dystonia indications, maybe blepharospasm or so, where you have only 2 or 3 muscles maybe, and they are all very obvious, and the treatment schemes, injection schemes, are very much standard, from the doses, from target muscle selection. All this is not the case in cervical dystonia. Cervical dystonia is a very individualized form of dystonia, so that means the clinical presentation amongst patients with cervical dystonia is absolutely different from patient to patient. So you will hardly find any cervical dystonia patient who is the same like the next one. So, and this has to be reflected in the injection scheme. And the injection scheme becomes particularly difficult because the number of potential target muscles in cervical dystonia is pretty large. There are maybe 20 or 30 or so muscles that we can choose for our treatment, and the question obviously is which one to choose, and the next question would be what doses should we apply for these muscles. So those are the things that we have to decide before we start the treatment. That is what goes into the injection scheme, and I will show you through the injection scheme development in this talk for the next 20 or so minutes. Can we put the next one on? Next slide, please. Oh, I can do it myself, yeah. Can. Which one? Okay. Oh, that's our motto, Scientia Bene Movendi. So the art of nice and elegant movement, that's what the motto of our department is. Yeah, so what are the steps we have to cover when we are developing the injection scheme? Starting point, as you can see here, is the clinical symptomatology. We have to describe the clinical symptomatology. We have to describe the dystonic deviation of the head and the neck. And from there, if we know the physiological functioning of the muscles, we can jump to the next step. We can jump to the selection of the target muscles. There are things to be careful, caveats. It's not always what the patient presents to you is not always the real dystonic posture. Quite a few patients actually have preventing postures, so that is automatically, not necessarily knowingly, they try to put their head in a position to prevent the burst of the dystonic movement. So I've seen patients who have actually had a head rotation to the opposite side where the actual dystonia was just not to jump into that position where the dystonia breaks out. So you have to be careful about what you see to make the decision on the target muscles. And from the target muscles, we have to come to the next step, what dose in the target muscle. And for that, we have to consider the severity of the dystonic involvement of the particular target muscle. Clearly, we want to give as little toxin as possible and as much as necessary. So for each target muscle, we have to decide, is this a very prominently involved muscle, or is it a muscle that is only, partially involved in that whole dystonic presentation? So we have to make a judgment on the severity of dystonic involvement of the particular target muscle within the whole set of muscles. And then to come to the actual dosing, we have to refer to dosing tables. I will show you example of that. So for each target muscle, we have developed by statistical analysis of what we have been doing in large numbers of patients, 300-400 patients, cervical dystonia over the last 20 or so years. They're all in our database, and we analyzed what was the dosing in each target muscle for each of the patients out of that group. And we came up with a clear description, statistical description of the mean dose, the variability as given by the standard deviation, and minimum and maximum dosing. So, and then once we have decided on the target muscle dosing, then we have completed the injection scheme development. And then the last step is, of course, if we know what we want to do, we have to do it. We have to apply the doses in the right muscle as we have, decided upon in the dosing scheme. And that is, I can show you with photos from a photo atlas we developed some time ago, how to identify the muscles. And just straight on, in cervical dystonia, I think we have no need to apply, additional technical guidance methods like EMG or ultrasound. These muscles we are injecting here are very, directly under the surface of the skin. We have excellent anatomical landmarks to identify them. We have our hands, we can palpate them, we can ask the patients to activate them. So that is all what we have to do then for the actual application. So this is the flow chart, if you want, from the clinical symptomatology to the toxin application, the development of the injection scheme as an intermediary step. And so this is basically what we have to do before we start a botulinum toxin therapy. One word, we have to do this on the first visit, when we first see the patient. We should see that patient in a clear naive situation. So I would suggest really not to develop or try to develop your injection scheme in a patient who was just recently pre-treated by somebody else. That can happen. We get a lot of patients for secondary referral, and they come and say, it didn't work the last time, and it was 3 weeks ago. I'm getting nervous now. Please, you're the expert. Try to improve my injection scheme. We have to say, wait 2 months, 3 months, so that the effects of the previous injections have been worn out, because otherwise you're completely confused by the effects of the doctors who have previously treated the patient. So starting point is really, you have to document the naive situation, then you can draw your conclusions, then you can develop your injection scheme. And just a word of advice, once you have developed your injection scheme, yes, you have to be flexible. Patients are reporting back, patients are different. Your injection scheme basically is a suggestion, is an estimate. The more experience you have, the better that estimate is. But even in very experienced injectors, patients may respond not necessarily as you have predicted it. Then you take the feedback, then you modify your injection scheme. But the word of advice here would be really not becoming hectic, not becoming, overwhelmed, maybe especially when a patient is very demanding and, say, we have to do something and it's not working. Stay calm, stick to your injection scheme, look from the distance saying, okay, he had a neck instability, we have to reduce some appropriate doses there in some target muscles, that's fine, but never really make abrupt, complete changes. So the rule of that game here is really stability, reliability for the patient, for yourself as well. So I said we would start with the description of the head and neck deviation. So the crucial point, I think, here is to understand the mechanical system. You don't have to understand all the details. Just 2 elements you have to bear in mind. That head and neck system is defined by 2 elements, the head and the neck. The neck and the head. Those are the basic 2 mechanical elements involved in that system. And in between, there is this joint there between the neck and the head. This is an absolutely remarkable joint from the mechanics side. It's a joint that is basically has all degrees of freedom any joint can have. It's so that you can rotate it, you can bend it, you can flex it wherever. It's like balancing a ball on the tip of a needle. So which makes the head control a very delicate thing, which I think is the reason why errors in dystonia can occur, because the control of the head on the neck is extremely complicated and is under the influence of many controls, acoustic, visual controls, movement feedback and so and so. We are talking about really a complicated mechanical system, and part of it is due that you have to balance your head 24 hours a day, or how long you're awake, on that tip of the needle of the neck. So you can basically separate the head and neck deviations in two groups. There are the simple ones where only one joint is, one element is involved, and the complex ones where more elements are involved, more joints are involved. Here, the most common form probably of cervical dystonia are rotations on the horizontal plane. So the head and the neck are rotated. In this case, there is no separation between the neck and the head. You know, you cannot rotate the neck in a different direction than the head. It's only this one rotation. So that's a very common form of cervical dystonia. That's how dystonia originally was described, right or left lateral collis. So, and then we have some more simple head and neck deviations here. The head extension in that joint between the neck and the head. So the head is just moved backwards or forward. You can see that in the next slide, or where the whole neck is moved or flexed on the connection to the rest of the body. And so, you know, as I said, extension, flexion on a sagittal plane, that is what here these forms of simple deviations are describing. You can also have the frontal plane, where again you have simple movements. The head is tilted, or the whole neck is tilted, sideways, either way. And then we come to the complex head and neck deviations. That is when there are movements in two joints. So here you have head and neck flexion, so the neck is flexed, and on top of that, the head is flexed additionally. Same backwards. You have it sideways as well. And you know, it's really important to distinguish the movement of the neck and the movement of the head, because the muscles are different for doing this. And we have to analyze which ones are involved. Here is an important important form of head deviation, complex one. You have the combination of a neck flexion and a head extension that produces a horizontal shift on a horizontal plane, anterior shift. You have the same backward posterior shift that can happen, or you can have a movement of the head basically sideways with a lateral shift. Yeah, so those are the basics of the mechanics of the head positions and the dystonic positions. We have to describe this, we have to document this as a starting point, and also for us then to make the decisions what target muscles we should address. So basically we have the sagittal plane, we have the frontal plane, we have the horizontal plane, and we can just mark which movements we see on each plane. Now it comes to the question, as I said in the overview, we have to make assumptions from the head position to the muscles involved, to the potential target muscles. There was this caveat we should bear in mind: patients may have prevented positions. Also, we have to bear in mind that the physiology we want to describe here is not necessarily working in dystonia, because dystonia is defined by unphysiological activation pattern. So there is something what I've seen quite frequently. For example, when we have a right rotation, we are assuming those are the muscles physiologically producing this posture. In the reality of dystonia, often we have co-contractions. It's actually a neurophysiological hallmark of dystonia. So we have simultaneous activation of opposite muscles as well. So quite often, you know, we are injecting antagonizing muscle groups. It's not necessarily in all the cases so, but it's not so if we see a right rotation that we should not inject the opposite muscles. Bear in mind, if necessary, if we have indications for that, we may also have to inject bilaterally opposing muscle groups. So what can we say for the sagittal plane head flexion? That is bilateral sternocleidomastoid, infrahiatal muscles, if you want to address them, risk of swallowing problems. Head and neck head extension is easy. The parasagittal muscles in the back of the neck, deep neck muscles, and splenius capitis muscles. So maybe at this point I should point out the relevance and importance of the deep neck muscles. Originally, when you go through the old literature, deep neck muscles were not used as target muscles. Similar like the scalenus muscles were not used traditionally for cervical dystonia, but it's logical when you go into the anatomy, go into the physiology, that you have to consider the deep neck muscles as well and the scalenus muscles as well. And when it comes to the neck extension, it's if there is a neck flexion, it's scalenus muscles, in particular in that combination of the anterior shift. It's the extension, it's the paravertebral muscles as well. And for the frontal movements, so the tilt of the head, it's splenius capitis, deep neck muscles, or when it comes to the neck, it's the scalenus muscles and the levator scapulae as well. And for the horizontal movement, the more classical, traditional head deviations, it's the contralateral sterno, ipsilateral splenius capitis. Remember the deep neck muscles, they are strong head rotators, and you have the paravertebral cervical muscles, the trapezius pars descendens. So I said, if we have decided after that process on the selection of the target muscles, we have to decide on a dose. And this is a kind of analysis we did in that group of cervical dystonia patients we had in our database. How many target muscles are there usually used? And you see here it's 5.7 target muscle on average. So originally, when you read the old literature, or also when you go to centers where there is not so much experience, they say, oh, right or left torticollis, splenius, sternocleidomastoid, 2 target muscles, that's the injection scheme. On average, we are dealing with almost 6 muscles. We can go sometimes in very severe, very complex patients up to 13. Well, we occasionally may have a patient where we only have a single target muscles. But just to give you an idea about the complexity of the injection scheme, usually we are dealing about 5 or 6 muscles as target muscles. And a word to the total dose. And you see we on average are in the range of 260 units. There is quite a variability. Excessive cases may go up to 800. That's really exceptional. Hardly total dose of less than 40 units. When you see these total doses of 260 units, you may say, well, I have read the registration documents for the drugs. For cervical dystonia, there are numbers of 120, 140, 160, 180 units. How come that you come up here with 260 units? I want to use this opportunity to tell you that the registration documents are misleading. The registration documents are based on registration studies. I have developed most of the cervical dystonia registration study designs myself. The purpose of the registration study is to produce a statistically significant effect so that the drug is registered, and at the same time you want to use a dose as low as possible in order not to come out with your product in the long list of adverse effects. So what are you doing as an effect of these two considerations? You're underdosing your patients. Or you are pre-selecting your cervical dystonia populations to exceptional mild cases. So again, being careful, registration studies are meant for registration. They are not guidelines for treating your real patients. So in reality, and I think over the years I've seen it, we are aligned with most of our experienced colleagues worldwide. We are dealing with higher doses than what is prescribed there in the registration documents. So this is a nice statistical, again, and graphical analysis of our database. We have here all the main target muscles: trapezius pars descendens, splenius capitis, SCM, levator scapulis, scalenus, and so on and so on. And what you see in the box, we have the mean value, 44.7 in the first one, 55 was there. And the box describes the standard deviation, the variability, and the red numbers are the maximum and minimum doses we had ever given in that large group of cervical dystonia patients. What you see is there is not very much of a variability for each target muscle. We more or less, we are in the range of maybe 30, 40, 50 units on average for each target muscle, and then sometimes we modify this going up to 60, maybe 70, going down to 20 or so. This is the kind of dose range we have to play with. So that will come out in a future publication for reference for you. And now for the rest of the application of the presentation, and I will be short with this, just showing, how to apply the toxin based on anatomical landmarks and on certain tricks, how to identify the muscles. Let me start here with the sternocleidomastid, the classical muscle here. What we do is we ask the patient to turn the head to the opposite side, maybe bend it over a little bit, and then automatically this muscle jumps out. Never do it in a relaxed position, never inject the relaxed muscle. You cannot palpate a relaxed muscle. You have to have an activation of your target muscle in order to really palpate it, to identify it. And then we use the one hand really to fix it so the muscle cannot move sideways or move anywhere else. We also have a feeling when we grip around that muscle about the volume. We have a very nice idea if we inject the needle how deep we are in the muscle. That's really one of the tricks we use for sternocleidomastid and for other muscles as well. And here, splenius capitis, there is this lateral triangle in the neck defined by the sternocleidomastid and by the trapezius on the other side. And then from behind the first muscle group there, after the border of the trapezius, is the splenius capitis. You can ask the patient to activate. You can roll over with your finger. You fix it with your fingers, and you use that hand. You use the one finger from your injection side, and you have a very stable position, even if the patient moves. Bear in mind, untreated patients, they come because they have had movements. They're not sitting there ideally still and wait for the injection. They move their head. But when you fix the muscle, when you have a counterpart for your injection hand, it's fairly stable. And the patient moves, you move with the patient, and you get your toxin where you're supposed to get it. Next layer then is the scalenus. Go high up there that you're not touching the plexus further down, and can activate the muscle, can bend the neck away from you, so then that muscle springs out again, and it's easy to identify. Levator scapulae, you ask the patient to lift the shoulder, you put your one hand on the shoulder so that the patient can activate against the force of your hand. That muscle jumps out, easy to do, you do it. Pars descendens, you feel the midline with your middle finger. You use that hand to rest your injection site on it, to control your injection, hand on that, and 2-3 sides maybe in the course of the muscle from the back of the head down to the shoulder. That's where you inject. Deep neck muscles, there's a lot of discussion. Of course, there are various deep neck muscles, and theoretically they have different functions. And if you get to the neurophysiologists, they're all slightly anarchistic. They say, yeah, I want to know which one we are injecting and so on, and how can we control it. My message is not necessary. They're a muscle group. When you do EMG, as we have been doing for many years, we hardly saw that there is much differential activation of that muscle group, so no need to try to identify individual deep neck muscles from each other. Inject the robust dose, 40 units, 20 units, in that order, into that muscle group. That does the trick. And if you want to do this, you don't need an EMG feedback. I've seen so many neurophysiologists trying to show me how they identify individual deep neck muscles. At the end of the day, I must say, never convinced me. There was no feedback about a movement, and the EMG signal was crosstalk all over. So it sounds nice theoretically. When you're faced with the practical issues, it doesn't work. So just use that muscle group as a muscle group, inject it, and you do the trick. Trapezius pars horizontalis is obvious where that is, and you do the same. Yeah, I hope I stayed within my time limit. Let's briefly summarize. The mechanics of the head and neck are determined by two joints with a high degree of freedom, two mechanical elements that interact. Somebody have called that caput collis concept. Why should we learn Latin for that? We have the head, we have the neck. We have to know that they are two separate elements. They are interacting. That's the basics of the mechanics of that system. If we remember this, then everything else becomes really easy. Yes, of course, these muscles are complex in their interactions. The numbers is relatively high. The variability of their dystonic involvement is highly individual. We have to make an individual analysis. There is no such thing as a standard dose we just give. We have to analyze the situation. I showed you how to do this. And the injection scheme for botulinum toxin of cervical dystonia can be developed in several steps. The description, then the physiology, which muscles are target muscles, then the dosing scheme, the dosing for the target muscles, and then the actual application of the botulinum toxin. Yeah, so I hope I covered everything. Thanks for your interest, and if you have a question and answer section, of course, I'm happy to go into more details if you want. Thank you very much. Thank you. Good.
What is the maximum dose of botulinum toxin you want to inject on one side of sternocleidomastoid?
Yeah, it's a discussion, that there are few discussions. Number one is, what is the dilution, what is the diffusion, what is the number of injection sites per muscle? There are no good theoretical data or experimental data answering this question. Intuitively, I would say the amount of toxin or of volume you're injecting at each injection site should be practicable. If somebody says, I injected 0.1 milliliter per injection site, I said, this is not plausible. You have washout with blood. So 0.5 milliliter per injection site, I think is a good volume. If you want to inject 40 units, it's 1 milliliter. You can use one or you can use two injection sites. Those would be my considerations about the injection sites and the volume. That would require 2.5 milliliter dilution. And the stuff goes around in the muscle tremendously. You know, for me, a very interesting observation was many years ago when, in the course of a study, we were faced with a fixed injection scheme, and that sponsor at that time said, we want to apply 10 mouse units in the sterno in one injection site in a volume of 0.1 milliliter. I said, you're crazy. You know, what are 10 units, 0.1 milliliter, practically not injectable. And we did it because, you know, part of the study required us to do this. And we saw a strong effect throughout the whole muscle when we checked it on EMG. So there are really widespread effects within that muscle. The muscle shield is shielded to some extent, so crosstalk into other muscles is not so much of a problem. We would have more adverse effects if that would be the case. Of course, I would target for more proximal parts of the sternocleido, not necessarily injecting it close to the lower end where it's adjacent to the swallowing.
What is the
muscles.
maximum dose in one side? Maximum dose in one side you routinely do?
This is pretty much around 40 units. If it's mildly involved, maybe 20. If it would be a massive hypertrophic muscle in a strong guy, maybe it could be 60. That's around that.
But if you're injecting in some situation bilaterally,
Yes.
do you reduce the dose on one side? Or is the same dose like both sides?
Depending, you know, if it's symmetrical, asymmetrical. No, I would not necessarily reduce the dose according to the question whether it's a unilateral or bilateral injection. If we think it's necessary, we do it, and if it's bilateral, we do it as well. There was a long discussion, like when I was at Queen Square, somebody said, yeah, we never, as a matter of principle, we're never injecting sternocleido bilaterally because that always produces swallowing problems. That's clearly not true. We have so many bilateral sternocleidomastoid injections not producing swallowing problems. I mean, if we are touching the issue of dysphagia, very complex issue. Yes, there is overall probably a relationship between the sterno dose and the frequency of dysphagia. But when you see it in reality, we have patients, stable patients on stable treatment for years, same doses. On some occasions, they have dysphagia. On some other occasions, most other occasions, they have no dysphagia. Yes, variability, the injector, maybe the injector is not careful enough and injects very deep. That could be reasons. But there is not a clear relationship between the doses and the injection scheme and the dysphagia. I think probably there is a lot of an element of an individuality of the patient. They may have preformed dysphagia as part of their cervical dystonia. Maybe they are more prone to have that. But you know, we have injections done in the neck, not in the front of the neck, in the back of the neck, producing dysphagia. Not with excessive doses, let's say 60 in the posterior part of the neck, producing dysphagia. So that relationship between dysphagia and dosing scheme is pretty variable. All I can say is don't be too afraid about dysphagia. You know, unexperienced people are always very much afraid about dysphagia because they think dysphagia means you are in the ICU, you get tube feeding, and you're in bed for 2 weeks. Exceptional cases that can happen, I must admit, but there must have been something completely wrong, you know. Usually when you see dysphagia rates of maybe 10-15% in studies, that means you have an alteration of the feeling of your swallowing process. You have to swallow twice. You're realizing that you're swallowing. That's the kind of dysphagia that is reported. So don't be afraid about dysphagia if you're staying within the usually accepted limits. It's not a risk. More questions if you have time? Yeah, please.
Thank you. It was an excellent talk. I wish you could have been my mentor when I was training. Just want to ask your experience about injecting patients with MSA with severe anticolis and also eyelid opening apraxia in PSP. Do they have sustained benefit? And if so, what do you want to share with us?
Yeah, basically you're referring to axial syndromes and Parkinsonian syndromes. It's obvious in the cases of MSA, but we also have axial deviations in patients with idiopathic Parkinson's. I must say, overall, the experience we have with these patients is not so promising. First thing is, what is, for example, axial deviation in cervical dystonia, in idiopathic Parkinsonisms? The answer is we don't know. We have, I think, when these Parkinson patients are bent over, it's not dystonia. It's not dystonia. Dystonia means there is somewhere a muscle overactivity, and we have checked these patients. We have done EMG in various parts. We have not seen muscle overactivity. I think it's a kind of an involvement, upper brainstem involvement in the Parkinsonian process of the centers controlling upright position. So it's a kind of apraxia, so patients falling over rather than being pulled over. So if you have that understanding of that process, it's clear that botulinum is not helpful. You have mechanical effects, yes, after a short period of time, this posture becomes contract. You have tissue alterations not responsible to botulinum toxin. Yes, maybe if you have an exceptional patient where you think I'm dealing with a muscle hyperactivity somewhere, you can try it. But bear in mind, postural deviations in Parkinsonian patients, either idiopathic ones, MSA ones, PSP ones, are usually non-dystonic. And if they are non-dystonic, the chances for botulinum is rather limited. It's a long discussion. Some people say, well, we have done EMG in the posterior muscles, in the spine, in the spinal column, the paravertebral muscles, they are atrophic. Again, that would not be an indication for botulinum. So what this posture is really caused by is still, for me at least, pretty much a miracle. Like here.
So I have just one query. Do you prefer to inject in retrocolis in a PSP patient? Recently, I have injected one, and he has shown some good result.
Yeah.
Yes, sir.
Yeah. That's where we have seen, in that situation, we have seen muscle hyperactivity.
Yeah.
That's for sure.
Okay, sure.
Right.
Thank you, sir.
Right. Yeah, also when you mention PSP, there is this interesting thing, there is a large percentage of these PSP patients who have lid movement abnormalities. I say this very openly, lid movement abnormalities. They may have an element of blepharospasm, active contractions of the orbicularis oculi muscle, but most of all, they have levator inhibition, so eyelid opening apraxia, and so that means they have half open eyelids, not necessarily because they have a blepharospasm component, but they cannot activate the levator palpebrae muscle. We inject these patients. Sometimes it works if we are reducing the balance between the orbicularis and the levator. It's easier for them to activate the levator, but overall that's not so successful. So we are preparing a publication when we analyzed our PSP patients. You should try it. Maybe it helps. But classically and interestingly, You know, when you go back into the history, Andy Lee is a good friend of mine. He was the first. It was actually in 1989 when he said, what are the patients with blepharospasm unresponsive to botulinum toxin therapy? At that time, being a Parkinson's super specialist, he said PSP patients, because the reason is they have a levator inhibition rather than an active blepharospasm with the contractions in the orbicularis oculi muscles.
If a patient with retrocolis who is not responding to routine doses, how often do you inject the OCI muscles, the posterior muscles, small muscles, obliquus capitis inferior?
Yeah, frequently. We would start with the more, you know, not the deep ones necessarily as a starting point, but if the doses are robust and there is still retrocolis, we go for the other ones. But that would be really a step process. We start with the more superficial ones and then would extend the scheme to the more deeper laying muscles. But overall, I must say this head and neck extension is very responsive to the toxin. It's a matter of the dose and additional target muscles maybe, if not started from the beginning, but can do that.
So if there are no further questions, a round of applause for Dr. Dressler, and also for his wife, who also helped us because she was a part of the presentation as well. So a round of applause for ma'am as well. Thank you so much, sir. With that, I'll move on